Hi, I'm Dr. Beatriz Molina, and today we got here lovely Pete, who is 48, and he said to me today that he's looking a little bit tired. So he's probably getting a little bit fed up of everyone asking him if he's all right. He has always had a little bit of a groove on the eye area and a little bit of an eye bag from very young age. So naturally, obviously, he never had a lot of fat along here. What we do notice, particularly obviously on the left side, is that there is a quite large flattening on the malar pad. So if we look to the side, we can see that his tear trough, I can put nearly the pen in there. So it's actually very hollow here. Now, because of his being just above the 40, he's obviously lost a little bit of volume on the submalar pad, and also his all lateral part of the face here is very flattened, which means the skin is going to drop this way, creating the beginning of the nasolabial folds and a very small amount of marionette. So in his case, it's a bit more complex rejuvenation. We cannot just treat only the eye socket. If we did, we only get a very mild improvement on the rim. We definitely need the malar projection here. So we don't want to feminine him because obviously men are flatter than female, but we still will have to put a very small amount of product here to support that part. So will allow me to then put some product on the rim to finish off. Of course, because of the flattening here and we want him to have a bit more masculine projection, we could put some product here because this will obviously lift laterally, which improves slightly his tear trough and also will help to support a little bit of the eye area as well. So in this case, we need to do possibly 2 entry points, one here first for the tear trough, one lateral here for the malar area, and then we possibly need later to finish the rim with the needle to do a small deposit and lift this part of the rim. So we're going to do in 3 stages, starting obviously 1, 2, and 3. So when we're treating the face in this area, we need to take the anatomical considerations and the risks for this area. So the first thing we need to look is, we always ask the patients to look straight ahead and looking at the pupil. If we go about 7 millimeters roughly before or slightly inside of the limbus, we're going to find the infraorbital nerve. So normally you can feel it, and if you press, it's a little bit tender for the patient. And as we can see, that is practically where I want to go with my product. So this is why it's important to visualize it first, mark it. There is a slight anatomical variations where they moved slightly to the side, but it's always going to be, for me, pupillary in the middle and about 7 to 8 millimeters below. Also here we got another small bundle, which again, it comes from the bone here, and it will be, when you go with your cannula across, if you're going too close to the bone, again, you can scratch that area. And if you use an access point here with a cannula for a lateral approach, again, you could bruise it quite badly if you're not careful. Of course, one of the other important ones, if we get you to clench Pete for us. When we clench, this is the front of the clenching, we find a depression here. So our facial artery is going to be coming from here, turning on the mandibular jaw on the bone, and then from here we'll follow a very tortuous path. We don't know exactly where, but towards the mouth. When it comes here, we'll divide into the 2 supralabial and the infralabial artery, and it will continue across into the nose. It could be exactly on the nasolabial fold. Sometimes there is anatomical variations which is on the inside, and also could be on the outside. From here, it will join most of the time with the artery coming in to feed the nose, and sometimes there is a whole anatomical from the angular. It will also feed through here and into the others, and there is obviously a lot of connections. So just to be aware, this is why I am choosing this entry point from here, so I'm away from large blood vessels, and also sometimes entry points either here or here to be away from the risk areas. So these are entry points with the various areas. Remember that the vein doesn't always go with the artery and sometimes go more straight across here. So again, if it's across here somewhere, we are avoiding, and that's why I like to use a cannula for this area, because you can very gently push blood vessels out of the way without causing a major problem. If we inject in this area on the above the bone, there are a lot of superficial blood vessels, a lot of big network of blood vessels, so the risk will be more when you're going through to perforate one, and of course you can cause a bruise. However, when you are on the bone, in here there is nothing major to worry about, so that's why it's important to make sure your needle or cannula is on the bone around this place, because it's safer to work on. And obviously, having had a little reminder of our anatomy and the importance and considering the risks, we can now proceed with the treatment. So our first step is going to be, as we can see on the drawing, one entry point in the middle of the face to do the part of the tear trough. Okay, so first of all, after a very good cleanse of the skin, following the tear trough, I'm going to use the lidocaine 2%, one small injection point. It stings a little bit when it goes in, so aspirate and then just put very, very small amount, slow and gentle. So that's it. So next we got our 23G needle, and we're going to do next to the previous hole, very small entry point for my cannula. As you can see, I'm only using the tip of the needle. Don't need to be rough with it. This is 23G, and my cannula is going to be a 25. So it will be plenty of room for it. Because it's a male patient, and obviously the skin is a little bit thicker than a female, in this case we're going to use GP to start with for the tear trough area, just a very small amount, possibly a 0.2 or a 0.3. So we got ready here the cannula 25G. As you can see, it's about 38 millimeters long, because this one allows me to go from the entry point exactly where I want without going above the orbital ring. So we'll prime our cannula, and then we're ready to start. So we hold the needle and the cannula together as is one unit, as a dart, and then we find the small little hole. It's gone through okay. Wriggle, wriggle. You can see, if I get you to turn a little bit this way so we can see the depth. Once I'm in the skin, then I can turn it this direction, because it's going to go parallel into the area. So in this case now I'm going to turn it at this direction so you can see the approach. So hold the fat pad, gradually change the inclination of the cannula, and then very gently, you can see I'm very gently wriggling. You're going to stress the skin a little bit and put your finger at the end here to protect the orbital ring. You can see how gentle. When I'm lifting, you can see there is some movement of tissue lower here, but we cannot visualize either the tip of the cannula or even the shape of the cannula. But if I put my finger, I can feel it slightly in there. He's comfortable, which is telling me that I have not touched that infraorbital nerve, so there is no risk. Maybe a little bit higher. Perfect. He's still comfortable. Yeah, it's still on the right plane. Once I relocate my hand to inject, put back the finger there, and then very slowly I'm going to start my retrograde injection. And remember, we're only doing the first few millimeters of the tear trough. So just about there. And when I put my finger now, I can feel there is a bit of product there. And now I need next to it, so I need to come back to my entry point, change the angle, grab again, go up again a little bit, and that's it. I feel the other pop. There we are. I'm really deep there. I cannot visualize it. So again, relocate your hand, by your finger there to protect the orbital ring, and then very slowly just inject a little bit more. So ideally, maybe about 0.5. Then come back to entry point, and this is our step 1. Okay, so let's get Pete to sit up so we can see after our step 1 the result of this tear trough. So we can see from the front there is a beautiful lifting on that tear trough over there, which is already even softened that beginning of there. And if I turn it slightly, we can see it's a nicer continuation here. And if we see the other side, we can see actually how much flatter that is in comparison. It is very natural, but it's already improved that look in the mid face. So our step 2 is going to be doing her cheekbone. So our entry point is going to be on the cheekbone area. So you feel it, it's the flat part, you mark it, and on a male, remember, then it's more horizontal and a little bit more angular. It has to be as curved and soft. It has to be sharper than in a female. And as we can see on the other side of the face, I have actually marked where I want to put my product. And because we don't want to exacerbate it too much, I will fill at maybe 0.5, and I will be using Aliaxin EV again because it gives me the maximum projection with less amount of product. Okay, so we get your face a little bit to the side. We are going to put in a small amount of light, okay? Aspirate again, small amount, and that's it. This allows me to then now use my 23G needle. We clean that down now. I should have a little bit of a bleeding point, and in front of the bleeding point I'm going to put my needle, just the tip as before. And also remember to disinfect, because obviously there is always facial hair or the hair. You will need to disinfect everything before we use a cannula, because you got a little risk of contamination if the cannula touches the hair. If you got obviously a lot of problems, you can always use a wet gauze across. In this case, obviously he's nicely shaved, so it's not a problem. So then we get our product. As we said, it was going to be EV. Hold it again like a dart. Find your small hole. Perpendicular is already inside. Simple. Pinch a little bit. Wriggle until you feel then the surface of the bone. There we are. I feel like a little pop. And then I'm going to turn my cannula gently to go parallel in that direction, which is what we want to do on the cheekbone. And then just very gently glide it. You can see how easy and soft it is. He's comfortable. Again, you're trying to raise your cannula because we want to be above the bone, so super periosteum. We shouldn't see any relief. Then relocate your hand so you're comfortable. Put your finger, if you wish, on the end tip of the cannula because you can feel the extrusion of the product, the extrusion force. And then very gently and very slowly, we are going to do a retrograde. So we're going to do about 0.2 in each strand. And then I think we need to do, come back to entry point, go just above that one, only very slightly, a few millimeters, relocate my depth, finger again, and then again very slowly, backwards, 0.1 to 0.2, and then again entry point, and now below the previous one, gently wriggle, again perfect, lift again, I'm on the right plane, I'm going to feel again my finger so I know my cannula is there, and from there we are going to very, very gently and slowly do another lined retrograde. So in total about 0.5. So what we have done is what we said earlier, we recreate is one entry point and about 3 lines in there. Remember always on the peak is in a slight amount of more product than at the beginning and at the end because it's still a curve, but it's not as a strong curve as in a female. It has to be more striking, more sharp. So what we will do in a second is just to see what the result is. So we're going to get you to sit up. So just to recap, we did another insertion point here and we use EV across the malar area to just continue better the shape. So as we can see here, it's quite flat. And now looking at that side, there is a nice shape. And when we look on this direction, there is a very lovely natural looking result there. This will allow me now, as we've done a step 1 and a step 2, to be able to go now on the rim. Even if there is already an improvement, so if you want to do it in stages, you could stop here and leave that one for the next treatment. Otherwise, obviously, you could do all in one sitting. So let's do that next. For step 3, one more injection of lidocaine. In this case, we're going to go just outside that orbital muscle, periocular muscle. A small amount of lidocaine again. Then we're ready now to go with the 23G needle, as we've done before. Remember, just the tip, gently. I always tend to pinch because it distracts a little bit. And in this case now, because we're in the eye area, we're going to go for SR. As you remember, SR is a softer, it's more like a more viscous, a little bit more also very elastic. It's a bit like, I call it like honey, because it will spread very nicely. So holding as a dart, we find the little hole, pinch again, do the same thing up for the cheekbone, just wriggle it in, you feel in a small pop, and then again we have to rotate the whole needle, syringe, just to go parallel, because the rim follows that direction and that direction. We need to watch the way we tilt it. So first we start parallel to the outer part. Once we get about there, we can see we tilt, we start lifting this. So the back of your syringe, we start lifting and you start walking the bone to the front. I'm even going more forward again, and then a bit more, and a little bit more. Because now this is a flat part here. So this is like a curve. When I'm in the right place, again, trying to lift it, you don't visualize anything. That means I am under the orbicularis muscle. So I'm in the right place. I'm going to put my finger so I can feel where my tip is, and it's exactly there. And again, you protect the rest of the orbital ring, so above, and then you do a very slow retrograde. And again, you can see how I'm moving the back of my syringe. First it's going like this, then I've done that bit, so I'm turning it sides because it's a semicircle, and I'm following, and again more, and I'm following a little more and a little bit more. When I get here, I'm a bit below, so what I want to do is go back to my entry point, then lift it towards that little canthus there, and you can see from the pressure where I am, and just put a very small deposit, fill it, go back if needed, check, a little bit more. Let's go back, and then just place it again a little bit higher this time. So first and then second is slightly above, and again I'm deep, you cannot see no movement. So I'm putting my finger and I can just feel the tip right there, because I want to put a product now along there. So just again very little, and this will allow me to cover a little bit of the eye bags by making it very safe. So let's just stop there. It's a very lovely soft product, so you could just feel it. It's more like a molding, just to make sure I'm feeling every gap and I get a more continuous spread of the product. So let's have a look and see what this is done now. Now we're going to have a look at our third step. So the plan was, as we said earlier, is to do around the orbital rim. So as we can see here, we removed that line. This was quite hollow in there. And just by using our SR, we have definitely softened that groove. It's all looking very, very natural. So the entry point was just here. We can see a little bit of the hole still. And then we just place the product along the rim. And again, it's been sort of feather into the cheekbone area, but not as much as we did on the female patients, or we do normally on a female patient, because it needs to stay more angular with that more striking result. So I think we all agree that it's been a very good result, and we use it for 0.8 of SR in that rim, 0.5 EV, and GP 0.3 on the cheek, on the tear trough. So hopefully Pete is happy with the result. I think it's done really well. It's definitely rejuvenated, and I hope you enjoy it. Okay, so on the left side, I would like to showcase how to use the needle instead of the cannula to work on the orbital rim. So we get this time a GP with a needle coming from the blister pack. I use it like it's a little dart again, and we're going to go first on this injection point in the middle below the back, perpendicular onto bone, avoiding those lovely blood vessels there. Got a little bit of a sharp pain. You can pinch a little bit if you want. Okay. And then you can put, relocate your hand, a very small deposit, just like a little drop, aliquot. If you feel confident, once you know you're on the bone, you could actually tilt and follow the rim. Again, checking your depth this time. You feel the resistance, you kind of lift anything, and then feel with your finger. You shouldn't feel anything either. And again, a very, very small amount retrograde. We don't want to overfill it. And then coming back from injection point, you come up. Should be, you see no much bleeding or anything, so that's a good sign. We still put a bit of pressure because we don't want to bruise in case there is a small bleed, but as I said, this time it's very good. And then we just repeat the same thing next to it. So again, we hold it, go next to that one, maybe about 0.5 centimeter, stress the skin, find those little blood vessels to try to avoid them. Go straight onto bone, that's the bone already, we can see it's not far. And again, you could either relocate your hand and then just doing a small deposit straight there. And again, if you feel brave, rather than move, you can move to the next one, or you could just tilt your needle following that groove. Again, checking that there is resistance, and then placing a small amount of product in there. And then again, come back to entry point, out, and perfect. Voila. So you can see it's lifted very well. Okay, so in conclusion, let's have a look and see what we have done today. So we have treated the tear trough, a little bit of the cheekbone for projection, and the orbital ring. On the right hand side, we use GP, EV, SR. On the left hand side, we've done the same thing, but then we also did a couple of deposits with GP on these 2 points, because this was the flat, as we said at the beginning, side, and it needed a little bit more support. So we used the GP with the needle. We put 2 small deposits just to get that extra support. We all agree that he's still a little bit flatter in general on the left side to the right side, but that's how he always have looked. So it's for the first treatment, it looks good enough, it looks fresh. I think he seems very happy. So I think in conclusion, we agree that it's a very natural looking result, and hopefully you enjoy it.